Hello, everyone. I'm Dr. Leslie Kernisan, board-certified geriatrician and founder of the website betterhealthwhileaging.net. And this is the Better Health While Aging video podcast, where we discuss common health problems that affect people over age 60 and the best ways to prevent and manage those problems. In today's episode, I'm going to review the basics of a very common issue that affects older adults, and that is urinary incontinence, meaning leaking or even frankly passing urine when you don't want to. This is also sometimes referred to as a loss of bladder control. Now, urinary incontinence is a problem that affects both women and men, especially in later life. But since pelvic anatomy does make a difference when it comes to common causes and treatment options, I'm going to cover women and men in 2 different episodes. And in this one, we'll focus on urinary issues that affect women in later life. Specifically, in this episode, I'm going to start with the basics of female bladder and pelvic anatomy and how urination is supposed to work. And then I'm going to explain the 5 types of urinary incontinence that can affect women, how urinary incontinence should be evaluated, treatment options for incontinence in older women, what to know about Kegels, estrogen, and Pessaries, medications for incontinence, special considerations in geriatrics, meaning special considerations when people are especially old or frail, or maybe are having memory loss or cognitive problems. And lastly, I'll finish with what to do if you're concerned about urinary incontinence. So that's what we're going to cover. But before I get into that, I have a very quick request, which is if you're here, you find this topic interesting, or you've been finding my video podcast interesting, if you haven't subscribed yet, could you please go ahead and subscribe? It would mean a lot to me. It does help me out. It helps other people find the channel when you subscribe, and it helps support the work that I'm doing. Another option, if you appreciate my making these videos, is to become a member of this Better Health While Aging YouTube channel. And to learn more about that, just click the join button that's right under the video. Okay, let's now get to urinary incontinence in women. And to really understand the types of incontinence that affect older women and how we can treat them, it's really helpful to first understand the basics of the anatomy of the female bladder and how urination works in women. It's similar in men, but men, as you may have noticed, have a little bit, different anatomy than women do. So basically, urine is produced in the kidneys and then drains into the bladder through the 2 ureters. So you have 2 kidneys. They're located kind of on your backside under the ribs, and the ureters are the tubes that drain into the bladder. And then from the bladder, urine exits the bladder through a single tube, which is called the urethra. And in women, the urethra is actually fairly short. And there are 2 sphincters for the urethra. One is internal, kind of right at the outlet of the bladder. That one is not under your voluntary control. And then there's an external one, and that one is under voluntary control. So when you're trying to hold it, you're generally working with your external urinary sphincter. And so in terms of the bladder is a muscular organ. It's actually made of a special type of smooth muscle, and it's designed to store urine until you feel like it's the right moment to let it go. So as urine accumulates, because it's draining down from the kidneys, the bladder stretches. And as it stretches, that starts to send signals to the brain. The more it's stretched out, usually the more the bladder will be signaling to the brain. And that's part of what gives you that feeling like, I need to pee. And then normally for urination, at a certain moment when you consciously decide that it's appropriate, the brain initiates urination. That's a whole kind of coordinated sequence involving your muscles and nerves. And it basically causes the bladder to contract, and also the urethral sphincters, there's a mouthful, to relax so that the urine can come out. And that is how it is supposed to work. So what's important to know is that for normal urination to happen, it does require normal nerve function to coordinate that. And so as I'll explain later, one potential cause of incontinence is problems with those nerves. And I would say that's actually not necessarily the most common cause in older women, but normal nerve function is necessary for normal urination. So that's the bladder. But there's another part of the anatomy that's really important to understand as well, especially when it comes to women. And that is called the pelvic floor and also the pelvic anatomy. And by that, I mean the other organs in the pelvis that are very close to the bladder in women. And so what you'll see if you look at this cross section of a woman's pelvis is that in the pelvis, the bladder and the urethra are very close to the vagina. They're right in front of the vagina. And then right behind the vagina is the rectum. So all those organs and spaces are in close proximity, and that means they can affect each other. And it is potentially something that can cause or contribute to incontinence, is something going on with the rest of the bladder anatomy. And then those organs are resting on top of a layer of muscle, which is called the pelvic floor. It's a layer of muscles and ligaments. It kind of makes like a bowl in the bottom of the pelvis. And it extends from front to back, from the pubic bone to the tailbone. And then it also extends side to side between, what we colloquially refer to as the sits bones, the bones that you feel, when you sit down in a chair. And there are 3 openings in the pelvic floor for women. One for the urethra, that's the one furthest forward, then one for the vagina, and then one for the anus. So also to have continence, the pelvic floor muscles are involved. When we, squeeze and try to hold it, to hold our urine, or possibly our stool, we're generally tightening pelvic floor muscles. And those muscles also need to be able to relax to allow urination or pooping, if that's the activity at hand. So why does this matter? It matters because it's actually fairly common for women over the course of their lifetime to develop what's called pelvic floor dysfunction, meaning that those muscles are either not as strong as they should be, or maybe aren't operating quite well. And that can definitely affect urination and can be a contributor to incontinence in later life. Why do women develop pelvic floor dysfunction? A really common cause is childbirth. Just carrying all that weight when we're pregnant, plus the stress of pushing out a baby, often affects the pelvic floor. And so especially if one hasn't, done a lot of work afterwards to kind of rehabilitate those muscles, one can have a chronic weakness there that can affect urinary issues. And there are some other factors that can affect pelvic floor dysfunction as well. So now that we've covered the basics of the relevant anatomy, let's talk about urinary incontinence specifically. So first, I want to speak to why should it be medically evaluated in the first place? Because I found that this is something that often women are not mentioning to their doctors. They may think that, well, it's really common. They may think that it's part of getting old. They may think that there's nothing to do. And it's true that it is common, and it becomes more common as women get older. But there are things to do, and it really is an important issue for health and for quality of life. Lots of research has shown how suffering from incontinence issues can negatively affect women's well-being. It can affect their ability to feel like they're going out and about in their lives. It can affect anxiety and depression. Also, like often wetting yourself can potentially be the sign of a significant health problem or can cause skin issues. So it is really an important issue. And even though it is common as people get older, it should never be chalked up to just getting old. Because when we chalk things up to getting old, that often leads to this belief that there's nothing to do about it. And that's not true. Incontinence can be treated and managed. And it does usually start with a good medical evaluation. And I'm going to talk about what that should involve. And part of why we need to do the evaluation is to come up with a plan for treatment and management. How successful the treatment can be depends on many things. One is going to be identifying the type of incontinence. In a moment, I'm going to take you through 5 different types of incontinence. It's also important to identify whether there is any related prolapse or pelvic floor issues. So prolapse means that some of those pelvic organs, often it's the uterus, sometimes it can be another part of the pelvis, is sort of sagging downward and exerting a lot of pressure on the bladder or on another part of the pelvis. So if that's happening, that's going to affect continence, and addressing that prolapse can help with continence. And then successful treatment also depends on identifying and mitigating any other exacerbating factors that can contribute to or worsen incontinence, such as medications, excess weight, and, there are a few others that health providers are supposed to look for. So let me now take you through 5 types of urinary incontinence that affect women. These are often also going to affect men, just some kinds are more common or less common in men than in women. So we'll focus on how common they are in women for this episode. So first, I'm going to start with stress incontinence. So this is the kind of incontinence that happens when women leak urine when they exert themselves, when they sneeze, when they cough, when they jump up and down. So basically, when there's kind of like force exerted, again, downward on the bladder, on the pelvic floor, women might leak just a few drops, or they might even have a big gush, and that is called stress incontinence. Another type of incontinence is called urgency incontinence. And this features usually having sudden, strong urges to pee and maybe not being able to control it, so they might have like a little leak or a more significant leak. Now, some women just experience urge. They often get that crazy strong urge to pee. Maybe it's not even been that long since they went to the bathroom, and maybe they're able to hold it, but they really have to hustle to the bathroom. It's uncomfortable. It's distressing. So if there's leakage, that would be called urge incontinence or urgency incontinence. And it is related to something that is called overactive bladder, which is kind of this syndrome where the bladder seems to just often start contracting or sending that signal, I got to get emptied fairly easily, fairly often, maybe even when there's not that much urine in the bladder. So the third type of incontinence to consider is called mixed incontinence. And it's basically when people have a mix of stress and urge, not all that uncommon. Another type of incontinence is called overflow incontinence. Now, this type of incontinence happens when the bladder gets very, very full and is not emptying properly for some reason. And so once it gets so full that it can't stretch anymore, the pressure inside the bladder is going to start forcing urine out, even if the person doesn't want to pee or is trying to hold it. So in this kind of incontinence, people will often experience sort of like frequent little dribbles or leaks that happen. Why does the bladder get so full like this? This is actually a type of incontinence that's more common in men than women. But one potential cause is that if there's a problem with the nerves that's keeping the bladder from squeezing, that could cause it. Sometimes if there's something actually blocking the urethra and making it hard for the urine to come out, then the urine can tend to get backed up in the bladder until there's just so much backup that, again, that exerts enough pressure to force some urine past the blockage. Overflow incontinence is not that common in women. We do see it more in men, in part because men have a prostate around the urethra that tends to get enlarged, and that can more easily cause blockages. And then the fifth type of incontinence is called functional incontinence. And this is incontinence when people leak or wet themselves because they are experiencing physical or maybe cognitive impairments that interfere with them getting to the bathroom and toileting. So somebody who has a lot of mobility difficulties and it's very hard for them to get up out of their chair into the bathroom might end up leaking because of that. Or somebody who has developed a lot of memory problems and isn't kind of noticing that they need to go to the bathroom or is forgetting to go, might go. And so that would be called functional incontinence. And it is, of course, possible for functional incontinence to be combined with one of the other types as well. So given that, how should urinary incontinence be medically evaluated? So the purpose of the medical evaluation is to start identifying what do we think is the underlying type or types of incontinence and what are contributors, right? That we either need to know about or that we could manage to help reduce the incontinence. So this starts with an interview to get information regarding symptoms. So for instance, the health provider should ask questions to find out how often are you experiencing, leakage or urge? How much urine is coming out when there are leaks? How severe does this incontinence seem to be? What are things that trigger it, right? Is it only happening when you're jumping up and down? Is it happening mostly during the day, during the night? What is the strength of the urinary stream, right? Is it a strong gush or is it often like very weak or dribbly? Those are some of the things that they should be asking about. And some practices will even have a questionnaire, which can be very helpful sort of, to help you get down the relevant symptoms. And then the interview is also to ask additional questions because, again, they're trying to find out, could there be related medical conditions? So, for instance, I did a few videos on diabetes earlier this year, and when people's blood sugar is quite high, that makes them urinate more, right? And so sometimes incontinence can be caused or exacerbated by the fact that somebody's just generating lots and lots of urine and having difficulty managing that. So that would be another thing that they might potentially be considering. Your health provider should ask about your fluid intake overall and also about alcohol and caffeine, since both of those can affect the bladder as well. And what really helps is when people who have been experiencing incontinence are able to bring in kind of more data or information about exactly how often. So if you can come in having kept a diary for a few days, how often are you going to pee? How often are you having leaks? What's happening around those leaks? That can be extremely helpful. Next, as part of the medical evaluation, should be reviewing medications. That's because there are medications that can exacerbate incontinence, potentially cause it, but usually they're making someone who's already maybe a little bit prone to leaking worse. So we want to notice that, identify them, cut them back, and stop them if possible. And then there will be some kind of physical examination. It'll depend in part on what kind of symptoms, came up during the history. Now, incontinence is often initially evaluated with your primary care provider. And in that case, they often do not do a pelvic exam in women who complain of incontinence. And it's not clear that it's really necessary, often just from the history and maybe a little bit of examination, depending, for nerve function and things like that. They might have an idea of what type of incontinence it is and be able to sort of make suggestions. But in other cases, a pelvic exam to sort of check again on that, function of the pelvic floor, make sure there's no prolapse can be useful as well. Lastly, many experts recommend that health providers do a urine analysis when somebody is complaining of incontinence. And they're looking, for blood, either obvious or microscopic. They're looking to see if there are signs that there are problems, with the kidneys, and also looking to see if there might be signs of that could be a urinary tract infection. Now, should they get a urine culture? Well, only if there are other clinical signs of urinary tract infection. So it's true that having leakage could be a urinary tract infection. But first of all, in that case, the leakage should have started relatively recently. And second of all, people should have other clinical signs. I have a whole video that's about the signs of urinary tract infection and why you don't just want to do a culture if somebody has no signs, but they include things like fever, pain when you urinate, pain in the lower belly, pain in the low back. If there are just no symptoms at all, and the person has been having leakage for a long time, we don't necessarily want to get a urine culture. And that's because some older women are colonized. They just have bacteria in their bladder. That's quite common as people get older. And again, if you want to learn more about that, please see my related video on that topic. So that's how urinary incontinence should initially be medically evaluated. And then there is the possibility of some additional evaluation depending on the symptoms and on whether the primary care provider thinks some additional evaluation would be helpful. My favorite place for women to go for additional evaluation is urogynecology clinics. You could also go to urology. So what is the difference? Urogynecology clinics are clinics that focus specifically on women and female anatomy and urinary issues. They are often staffed by nurse practitioners or physician assistants who have a lot of experience helping women with incontinence. And then they also have physicians there as well. Often the physicians, will focus a little bit more on things that, have reached to the point where, maybe they're considering surgery. So some of the things that can be done in urogynecology clinics or urology, one is checking what's called a post-void residual. So this is basically checking to see how much urine is left in the bladder after the person has finished peeing. Because normally there should not be too much urine left in the bladder. But if there is more than expected, that can give the providers a clue as to what might be going on. Some clinics have a special ultrasound that will check, or they will ask the person to pee, and then they'll put in a catheter and see how much more urine drains out. Also, especially in Urogyn clinic, the providers are very adept at doing pelvic exams to check pelvic floor function and to check for prolapse. They might also do something that is called bladder stress testing. The basic one is they have the person with a full bladder stand in front of them, and they kind of watch as the person coughs or jumps a little bit, basically exerts a stress situation, bears down to see if there is any leakage. And then there's also the possibility of something called urodynamic testing. This is a little bit more involved. They put in special catheters that can sense the pressure in the bladder. They'll actually put extra fluid in the bladder and see at what point the bladder starts contracting. Most experts think that this is only necessary for special circumstances. Like if they're still unclear on what exactly is generating the incontinence after a certain amount of evaluation. but it is, a possibility in these clinics. Now, there are some red flags that kind of indicate that a primary provider really should refer to the specialist. So let me take you through those very quickly. These include sudden onset incontinence, right? Some like out of the blue having like quite a fair amount of incontinence. That's unusual. That should be looked at. If there is visible or microscopic blood in the urine, but the person isn't having UTI symptoms, that also indicates referral for a specialist. They'll probably want to, repeat the test. And if there continues to be blood in the urine, then they might do something called a cystoscopy, where they go and they take a look actually inside the bladder to see what might be bleeding. Incontinence with neurological symptoms. If people are experiencing weakness or numbness in their legs, in their perineum, the area kind of around their butt, that would be concerning as well. If the providers realize that the pelvic anatomy is quite abnormal, so really advanced prolapse, some women will unfortunately get prolapse to the point that their uterus is almost coming out their vagina, or if there seems to be a pelvic mass, that would be concerning. If the post-void residual is persistently quite elevated, that would also be concerning. Or if it's hard to pass a urinary catheter through the urethra, they might want to know, well, why is it so narrow? Why is it so difficult to get in there? Or some people have had pelvic reconstruction surgery or pelvic radiation, often as part of cancer treatment, and that would be another reason to potentially get specialist help with incontinence issues. Let's now talk about treatment. So, given all that, how is urinary incontinence treated? So there are a couple general principles that apply to pretty much all forms of incontinence. And then there are some specific treatments that are designed for specific types of incontinence. So first of all, for all types of incontinence, providers should start by addressing any related medications and medical conditions that might be causing or worsening the incontinence. And then there are lifestyle modifications that are recommended for all types of incontinence because they are so helpful and they are effective when people stick with them. So first of all, treating constipation. Constipation can cause or worsen incontinence. So treating it can make a big difference. Also, when people are constipated and are having to strain quite a lot to pass their bowel movements, that puts a lot of pressure on the pelvic floor and can contribute to pelvic floor dysfunction. So we always want to check for and treat constipation. If the person is overweight, encouraging weight loss is another possibility. This used to be quite hard for people to achieve, but now we are in the era of drugs that have made it significantly easier for people to lose weight. So that, could potentially be something to consider. Smoking tends to make pelvic floor function worse, so stopping smoking is recommended. Avoiding drinking large volumes of fluid at one time. Limiting alcohol and caffeine tends to help. It's certainly worth trying to see if that helps as well. And then reducing total daily fluid intake to 64 ounces. That would be 8 cups, unless you happen to be, in an area where it's very hot and you're, losing a lot of fluid, or if you're exerting yourself a lot, then obviously you would need to drink more. And then also very helpful for most forms of urinary incontinence, pelvic floor muscle strengthening, and Kegels, which you may have heard of, are an example of this. So these are the exercises where you kind of squeeze the muscles in the pelvis. To teach women to do this, they will often invite them, to sort of imagine if you were like squeezing, a tampon or something down there. That helps strengthen the pelvic floor. And there are a couple ways that women can do this. They can do it on their own. You can use certain implements actually to help. And there are also physical therapists who focus just on this. And actually, if you would like to learn more about this, I'm going to post in the show notes for this episode. There are some excellent resources online from one of the Canadian provinces. They did a whole series on the pelvic floor with their pelvic physical therapists. And so that's a great resource that I want to recommend. Something else that is helpful for urinary incontinence is bladder training. So this is especially good for urge symptoms. And this basically means kind of doing a whole behavioral series where you notice when you have an urge to go to the bathroom and you train yourself to, first of all, go more slowly. Second of all, you observe yourself. How often are you going? And then you start to put yourself on a schedule and you don't go before the time. And then you slowly start to extend the time. And that's partly about getting the bladder used to being a little bit more full and getting the brain used to that and kind of reprogramming a bit the signals that are happening between the bladder and the brain. Bladder training has been shown to be effective, provided one sticks with it. So again, that often involves what we call timed voiding. So kind of putting yourself on a schedule for peeing and slowly extending the time between voids. Another thing that is very helpful and that women sometimes don't find out about is low-dose vaginal estrogen. So this is especially useful for women who are postmenopausal or maybe perimenopausal, who have had, their estrogen levels in their body drop, or who otherwise have signs of what is called, vaginal atrophy. So basically, estrogen helps keep the tissues in the pelvis, near the urethra, in the vagina. They help keep those tissues plump. And so when women's estrogen levels go down, those tissues get thinner, and that's what is called vaginal atrophy. So women sometimes notice that things are drier down there. It can make sex uncomfortable. But what women may not realize that it can also worsen incontinence, actually, because there's less sort of support around the urethra. The urethra works better to hold urine when those tissues are plumper. So this can be treated with what is called topical estrogen in the vagina. It can be applied with an applicator as a cream. Usually they start with daily application for the first few weeks and then a few times a week, or there are special rings that can be put in to deliver estrogen as well. So these three techniques often can significantly help women with their urinary incontinence symptoms, provided you stick with them for 8 to 12 weeks. So that is often the challenge, is that people are told to do this and for various reasons don't do it and then come back and say, I'm not better. And so one of the things that ideally their health provider would ask was, well, did you do these things? And if not, how can we support you in doing them? People may have been unclear on what the exercises were, or, again, referral to pelvic physical therapy sometimes helps quite a lot. So for most types of incontinence, these strategies are going to work. But there is an additional underused option that I want to mention. It's especially useful for stress incontinence, but many women don't know about it. And that is something called a pessary. So pessaries for urinary incontinence. What is a pessary? A pessary is a silicone ring that is placed in the vagina, in the top of the vagina. And the ones for incontinence have a special little knob on it that provides extra support to the urethra. And it actually helps reduce stress incontinence. Pessaries are also used for prolapse. So anyone who might have their uterus sagging down, a pessary can provide additional support. Those pessaries may have a bit of a different shape. So how do you use a pessary? How do you get a pessary? You do have to be fitted for a pessary, and this is generally done in a Urogyn clinic. So it might take them a little while to find the right size, the right style. They come in, a couple of different styles and shapes, and the placement. But once this is done, they are often comfortable and quite effective. So it's an important option to know about. Far too many women, if they bring up incontinence to their providers, are put on a medication and that's the end of it. And that is really a shame. There are these other options out there. And so it's important to know about them, ask about them, and see if they might work for you. And then once people have a pessary, there is the question of maintenance. It depends on the pessary. Some of them can be left in there for quite a long time and can be cleaned and changed in clinic every few months. If you go to Urogyn Clinic, this is one of the great things about Urogyn Clinic. They will be able to explain this to you in depth. And so that can help you determine whether this might be a good option for you. So those are some options for treating urinary incontinence in women that I hope all older women will find out about and consider exploring for them. Let's now talk about medications. So it is fairly common for women to be prescribed medication for urinary incontinence, but there are definitely some important things to know about medication. So first of all, the medications we have essentially work by reducing bladder contractions. This means that they can help with urge symptoms, but they do not help with stress incontinence. So if what an older woman has is just stress incontinence, medications are generally not going to help. However, lots of older women have mixed incontinence or might have some urge incontinence, and so medications might actually help. Next thing to know about medications is that until recently, all the medications we had were in a class that is called antimuscarinics. That's because the muscarinic receptors are a type of receptor in the bladder, and they are all quite anticholinergic, those in this class. So they include medications such as oxybutynin, tolterodine, solifenacin, derifenacin, trospium. The brand names for those are ditropan, Detrol, Vesicare, Enablex, and Sanctura. So they do reduce bladder contractions, but anticholinergics, I have actually talked about these medications because they affect the neurotransmitter acetylcholine, which is also in your brain. And so they can affect your brain function, your memory and your cognitive function. And I have a video about those medications, which I recommend you watch. They also, because acetylcholine works throughout the body, they commonly cause symptoms, side effects such as dry mouth, dry eyes, slower bowels, and then drowsiness, possibly worse memory or confusion. So because of this, these are medications that we don't like to use in geriatrics. They're on our list. It's called the Beers list of medications that should only be used, avoided or used with caution in older adults. But they do help some people with their incontinence, so it can be worth trying. However, if it's looking like you have urge symptoms and you're interested in medication, what might be better is to try one of the medications that's part of a newer class of medication. So starting, I think, around 2012, some newer medications came on the scene. These are in a class called beta-3 adrenergic agonists. So they also act to relax the bladder. They just don't work on those receptors that are involved with acetylcholine. They work on different receptors. And so the good news there is that they don't cause those symptoms like dry mouth, dry eye, sedation, and they probably won't worsen cognitive function. They do have some, side effects as well. So these medications, the brand names are Myrbetriq, Gemtesa. And again, they do stimulate the relaxation of the bladder. So the side effects tend to be less problematic in older adults. They do include some things like headache and changes in blood pressure, congestion. But often the big limitation is because these medications are newer, they are often significantly more expensive or may not be covered by an older person's drug plan or might require a prior authorization. So those are options. They just right now are less available than the older medications. And then the problem with the older medications is that they are anticholinergic. Otherwise, what you should know when it comes to medication is that it might improve symptoms as quickly as within a week, but it can take up to 12 weeks for full effect. If you talk with your health provider and you decide to try medication, I highly recommend, first of all, keeping a diary of your symptoms. It's important to know if within a few weeks, are you significantly better or not? If you're not significantly better, you want to let your health provider know. They might up the dose a bit. And then if after a few months you're not significantly better, especially if you're on one of these older anticholinergic medications, it's reasonable to ask yourself, well, is it worth staying on it, right? Because there is a risk to those medications. And so if you're not actually benefiting enough, then it might not make sense to stay on it. So those are the fundamentals of the first pass at treating urinary incontinence in older women. Let me now speak briefly to a few other treatment options that sometimes come up. I think of these kind of as next level treatments. So they're usually considered after a person and their health providers have spent several months trying the previous treatments that I mentioned. So some other options. Sometimes surgery is an option. There are surgeries that can kind of bolster the pelvic floor. You are still supposed to do your pelvic floor exercises, even if you're considering surgery. But depending on the type of incontinence, the pelvic anatomy, surgery can sometimes help. Another option, especially for overactive bladder, is actually Botox to keep it from squeezing as often. Depending on, again, the type of incontinence, if it seems related to nerve function, sometimes there are some special nerve stimulation technologies that are newer that are sometimes tried. Mostly what I want you to know is that I really recommend you do a trial of the lifestyle therapies and other first-line therapies before considering surgery or anything else really involved. Let me now talk about special considerations in geriatrics. As people get older, incontinence becomes more and more common for various reasons. And it is often more challenging to help older adults with incontinence if they're frail and older. And there are a couple reasons for this. So first of all, often, not always, but often, older adults who are having incontinence are also experiencing some problems with memory loss or thinking. So they have some form of cognitive impairment. Maybe they've even been diagnosed with a dementia such as Alzheimer's or a different type of dementia. And especially if they're having any problems with their memory or thinking, that can make it very hard for them to report symptoms or keep avoiding diary. So it can be hard to get enough information to understand just what type of incontinence they have. And then as we try treatments, it can be hard to know how much they are improving. And also, if people are, especially if they're having cognitive difficulties, but if otherwise they're frail, they're feeling sick, they're very tired, they may not have the energy or motivation or capacity to do those lifestyle measures such as pelvic floor strengthening or bladder strengthening. And a certain number of frail older adults are struggling with toileting due to physical or cognitive limitations, so they're experiencing functional incontinence. Lastly, frail older adults are more likely to experience cognitive side effects from those commonly used medications for overactive bladder. So this doesn't mean that we can't help older adults who have incontinence. What I would say is that often the approaches that are viable for us to use might be different than what we can do with somebody who's 70 and otherwise has a fair amount of energy and wherewithal and motivation to participate. Let me now share a mnemonic that we learn in geriatrics called diapers. It is a mnemonic to help us think of certain things when we encounter a frail older adult with incontinence. So D is for delirium. So delirium is, I don't think I've done a video yet, but I will do a video on delirium soon. It's a state of worse than usual mental function that often comes on when people are hospitalized or after a surgery, or if they're sick or under a lot of stress. So sometimes older adults develop incontinence, or it gets worse because they are experiencing delirium. Sometimes it's due to an infection. So it's reasonable to ask ourselves, could it be a UTI? But remember, we only want to treat a positive urine culture if they have other clinical symptoms such as fever, pain, or looking quite sick. Could it be atrophic urethritis or vaginitis? So that, again, is related to the low estrogen that thins out the tissues. I was explaining that earlier in the episode. Could it be pharmaceuticals? There are medications that tend to worsen incontinence, such as diuretics. If you want to see a list of those medications, I have a related article about incontinence on Better Health While Aging that I'll link to. You can see a list there. Psychological disorders occasionally are a cause of incontinence. Excessive urine output. So if people are experiencing heart failure or have high blood sugar, they might be releasing more urine than they otherwise would, and that can cause or worsen incontinence. Restricted mobility, again, a factor, especially in functional incontinence. And then stool impaction, constipation, another issue that is quite common when people get older. And I have a video about that too, if you would like to see it. So given all that, how do we manage incontinence in frailer older adults? It can be harder to really resolve the incontinence in some frailer older adults. So we still want to try to see if we can identify the type of incontinence, if possible, by talking to the older person, by observing when they seem to be having their incontinence. So having a caregiver track symptoms and fill out the voiding diary can be very helpful. And then often we end up just trying to manage it through, especially behavioral strategies. I have found that it's relatively few frail older adults who are able to stick with bladder training or a lot of pelvic floor rehab. So we might turn to something like timed toileting, like creating a schedule and making sure there's a plan and support to help the older person get to the bathroom on a schedule and encouraging them to go at that time. That's called prompted voiding. Vaginal estrogen can still help people who are frail and much older. Now, especially if people are having some difficulty with their memory and thinking, it can be hard for them to apply the vaginal estrogen themselves. But there is something called, a ring, a vaginal estrogen ring. I forget the brand name right now, which gets put in and then stays for quite a while. So that doesn't require daily or frequent application. And I have had some families find that that's been really helpful for a frail older person. A pessary, is sometimes also an option, even when somebody is frail and older. So this is why I'm, again, a fan of Urogynecology Clinic. And then often it comes down to also managing leaks and urination with pads and incontinence supplies and protecting the skin to keep it from being too irritated by using barrier creams, hygiene, regular changes. So that's where we sometimes end up when it comes to geriatrics. But especially when people aren't too frail or struggling with too many other health issues, it is often possible to make quite a lot of headway in treating incontinence in women through the strategies that I described earlier in the episode. So given that, if you're concerned about urinary incontinence, what should you do? So I really recommend you keep a voiding diary for at least a few days. Just keep a notebook where you jot down how often you pee. Did you get, urges before? Was it related to, movement, coughing, exertion? Is it a little? Is it a lot? Have you identified any other triggers? That would be very helpful. And then I really encourage you to tell your health provider and ask for evaluation and assistance. And hopefully they will take it seriously and ask you enough questions that you feel like they really worked with you to help you figure out what type of incontinence it is. Would it make sense for you to go to Urogyn clinic and get a little bit more evaluation? And hopefully they'll also offer you support on those lifestyle measures that we talked about that often help lots and lots of women. What you don't want to do is assume that it's normal aging or that there is nothing to do. And even again, for frail older adults, we can still be checking on medications, make sure there aren't medications that are making them worse. And we should still be able to come up with a plan to make the urinary issues more manageable. When you work with your health provider, I recommend you ask them what type of incontinence they think you have. I think it's useful to know, do they think you have stress, urge, a mix, or maybe possibly functional incontinence or overflow incontinence? And remember that the medications only treat urge symptoms, not stress. If you are going to take a medication, taking one of the newer types is likely to be safer for you as an older woman. Last but not least, vaginal estrogen helps most postmenopausal women with their urinary incontinence symptoms. So ask about that as well. Pelvic floor strengthening is a commitment, but it's highly recommended. It is something that you probably should plan on doing indefinitely, but can really help with incontinence symptoms and can also improve sexual health as well. If you're having difficulty following through with it, you can ask about special pelvic physical therapy to help you with it as well. And then, especially if you do experience urge symptoms, I would recommend considering bladder training as well. Last but not least, consider getting a referral to a Urogyn clinic to see if a pessary can help you. That's especially worth considering if you are experiencing stress incontinence or if it seems like you might have any form of prolapse affecting your pelvic floor. So with that, thank you so much for watching. And if you found this video podcast helpful, if you're here on YouTube, please go ahead and subscribe. It helps more people find the channel. I would also love to invite you to join as a member if you want to further support the work that I've been doing. If you've been listening to the audio version on the podcast feed, come take a look at this video when you get a chance. You'll see my key points, some helpful illustrations as well. So with that, thank you once again, and I look forward to seeing you all again on a future episode of the Better Health While Aging video podcast.